Good morning. I think we're going to start our event right now. I am John Sarushia. I'm the Associate Director for Corporate Governance and Technology at the Bipartisan Policy Center. Today, we're going to talk about the pandemic and artificial intelligence. COVID-19 has dramatically disrupted people's lives and reshaped society. It is an issue on top of everyone's mind. Our first speaker today is my colleague, Dr. Anand Parekh, who will give us a quick briefing on the pandemic. Dr. Parekh is the Chief Medical Advisor at the Bipartisan Policy Center. Since 2015, Anand has provided clinical and public health expertise across our organization. Prior to joining BPC, he completed a decade of service at the Department of Health and Human Services. Thank you for joining us, Anand.
John, thanks so much for that introduction. Great to be with all of you today. I want to thank John and Michelle, Natalie, and the BPC team. Of course, I want to thank Cotiviti and IEM, who've been terrific partners as well as leaders. And thanks to all of you for tuning in. So John asked me for a couple minutes just to set the stage for today's discussion and provide an update of where we are in America with respect to COVID-19. And so I think, as all of you know, worldwide, there are currently about 2.6 million confirmed cases of COVID-19 and approximately 180,000 deaths. And this comes from the Johns Hopkins University coronavirus dashboard. In the United States, approximately there are about 830,000 confirmed cases, as well as 46,000 deaths. Now, I think it's important to note that most of these are underestimates for a variety of reasons, but I think just those data points tell us that the United States is really at the forefront of this pandemic. We are about 4% of the US, of the world's population here in the United States. However, we represent about 30% of confirmed cases and 25% of deaths, just looking at that crude data. There are many models looking at the pandemic curve here in the United States. One of the more popular ones is one out of the University of Washington, the Institute for Health Metrics and Evaluation, which suggests that this particular wave that the US is in right now, through the end of May, if we continue our social distancing policies, there may be 66,000 Americans who lose their lives. There's a pretty large confidence interval there, from about 45,000 to about 123,000. So wide confidence interval, but we are right smack in the middle of the pandemic curve here in the United States. Of course, in a country as large as this with 330 million people, we can't really talk about one pandemic curve. Every community is experiencing the pandemic at a different point in time. And so we are seeing various community states across the country that are still on the upslope of the pandemic curve. Other communities, hotspots like the New York City region, we are beginning to see some plateauing, looking at both cases, hospitalizations, and deaths. So every community is at different points on that curve. But as I mentioned earlier, we are still right in the middle of this first pandemic wave. I think, as you all also know, there are three elements to the current response to the pandemic in this country. The first is from a community mitigation perspective, social distancing. 43 states still have stay-at-home orders. Most states have closed schools, closed non-essential businesses. As a result of that, reducing the contact rate, we have seen various indicators demonstrating that the R0, which is the transmissibility factor, this idea for every one person who has COVID-19 or who has the virus, that they will transmit it to 2 or 3 other individuals if no interventions are taken. We've seen that in many communities across the country fall to under 1, which is where we'd like to see it, because that really helps to suppress the epidemic. So social distancing is absolutely working. The second part of the response, of course, focuses on testing. And the first is testing to identify the virus. There we are upwards of about 1 million tests in this country per week. And there have been many experts just in the last few days who have suggested that we need to increase that many fold, at a minimum 3 to 4-fold, to really test the number of Americans that we need, those who are symptomatic, those who are close contacts, those who are essential workers, those who are hospitalized. So we do need a dramatic ramp up in that testing. Testing also involves surveillance, having surveillance systems to be able to pick up outbreaks. And then, of course, serology tests that hopefully at some point will be able to tell us when somebody has been previously infected and the potential for immunity as well. So testing is that second prong. And then, of course, the third prong is supporting our healthcare system, getting our healthcare system the critical medical material and the personal protective equipment it needs. Part of the reason for doing social distancing is not only to reduce the spread, reduce exposure, but also to reduce that surge on the healthcare system. And we are still seeing pockets across America, health systems that have less than 1 week of supply when it comes to personal protective equipment, for example. So in this context, as you also know, several days ago, the president released a new plan, guidelines for reopening America. It's based on a series of gating criteria that from a surveillance perspective, symptomology should be decreasing. Second, from a case perspective, cases ought to be decreasing. And number three, there ought to be hospital capacity. I will add an additional element here that I think it's going to be really important from an infrastructure perspective, that we shore up our public health infrastructure in this country. Already pre-COVID, there was about a $4.5 billion gap in terms of what the infrastructure needed to be to ensure the conditions of health across America. And now with COVID-19, the need for surveillance, epidemiology, as well as contact tracing, which we'll talk about, is going to be absolutely critical. So the public health infrastructure here is going to be important. So I think in this context, I think today's discussion about artificial intelligence, its many roles in response to COVID-19, from research to vaccines and therapeutics, to clinical care, to even from public health, monitoring and surveilling cases, as well as individuals who may have been exposed, doing that contact tracing. The role for AI here is tremendously important. So many opportunities. I will also make a note that with those opportunities come challenges. Privacy is one. If you think about contact tracing and monitoring, ensuring that we can balance personal privacy. As you know, we don't have a comprehensive privacy law governing personal health information in this country. So there are issues that we need to tackle as well. But there's a lot of promise here. And I think the discussion with two terrific speakers and the discussion John is going to moderate, I think will allow us to see AI in action. A lot of the opportunities we'll have a chance to discuss the challenges as well. So John, I will turn it over back to you. Hope this was a helpful context for the discussion. Thank you.
Thank you, Anand. No, that was very, very helpful. A lot of interesting information to learn, from sort of community mitigation to ramping up testing to sort of the public health infrastructure. Okay, so let's move on to the sort of next portion of our event. Actually, the original name of this event was AI in the C-suite, and we were going to explore how corporate executives were using AI in their business. The pandemic naturally caused us to change the focus of our event, but we are lucky that our two panelists are CEOs in industries that are actually very critical in the response to the pandemic. So Madhu, I'm going to introduce you first, and please raise your hand so people can see which one you are. Thank you, Madhu. Madhu Bariwal is the president and CEO of IEM. Madhu has over 3 decades of experience in disaster and emergency management, national security, and using information technology. IEM has supported the U.S. Department of Health and Human Services for 15 years in their planning and modeling for pandemics and the required medical responses. So thank you for joining us, Madhu. And Dr. Imad Rizk, let's get you to sort of raise your hand, is the president and CEO of Cotivity. For the past 30 years, Imad has used his extensive experience working with the healthcare industry to improve the quality and financial performance of healthcare organizations. Cotivity has launched a COVID-19 resource center to help track the pandemic and combat the spread of the virus. So thank you both for joining us. Before we begin, though, we are going to take audience Q&A via Zoom, so feel free to ask your questions via the Zoom function, and we will sort of pick questions towards the end. This is for all 3 of our speakers, so this includes Anand as well as the panelists. So with that, let's begin with the very first question. So this is for both Iman and Madhu. Can you both tell us about your company, what you are doing in response to the pandemic, and how you are using AI? And I'll start with you, Madhu. And Madhu, you are muted.
There. I think the thing that we have been doing for the last 35 years, I started this company in 1985, is really to look at safety, security, and resiliency, and particularly the use of data and information and technology and modeling. And so this has been sort of in our wheelhouse, as you mentioned, in introducing IEM and me. We have been working for about 15 years, actually, really since the anthrax attacks in 2001. We have been working with HHS, BARDA, and NIH on modeling for bioterrorism events as well as disease events like pandemics. So that work, which resulted in a couple of different presidential directives on how to handle a bioterrorism event, have been seminal to what we have done in the past 35 years. What we have been doing for COVID-19 is when it became apparent in early 2020 that this was a disease that was spreading really fast. We stood up a AI modeling capability for COVID-19 specifically. And we are currently running about 3.6 billion simulations a day for every state and 3 of the territories and over 350 cities and counties. We'll be pushing this information out to our state and local customers and giving them information on what to expect and down at the local level, because all disasters are local. So providing that information for the local consumer, for the city, and also for the state that says what is the forecast. And it's a 7-day forecast that we provide. Recently, we have gone to now a 5-week forecast looking ahead, because the confidence intervals get to be very large when you try to forecast way ahead in advance. So we have used a time frame that we think operationally is useful for our customers. And that's what we have been doing since the COVID-19 crisis started into 2020.
Great, thank you, Madhu. And Iman, do you want to answer the same question? So tell us a bit about your company and what you're doing with regards to the pandemic and how you're using AI.
Sure. Can you hear me? Because
yes.
I think I was muted by that. So our organization kind of focuses on the 3 pillars in healthcare. One of them is risk adjustment, which is basically identifying patients that are at risk and identifying the risk burden of patients. The second part is quality, looking at quality indicators and understanding gaps in quality and quality outcomes of care. So sort of the 3 major pillars. And then the third one is the appropriate payment based on the disease burden and based on the quality outcomes. So we kind of touch payers and providers around those 3 parameters, and we measured that a lot, and we sit on a wealth of data. So when we started hearing about COVID, and basically we heard about it in 2020, as Madhu said, we were like everyone else, thinking whether this is going to be sort of a more of a localized, like a SARS. And I think Anand, all of us were thinking earlier if this is more SARS or more H1N1. Well, it became very apparent very quickly in January that it was more H1N1 in contagion and more of the seriousness of a SARS, but it definitely wasn't going to stay localized. So at that point, we started to actually look at our data, and we sit on about 135 million lives. But we also, those lives are longitudinal lives, so we can measure them across some time. And so we started actually looking at all the different zip codes down to a zip code level of where we're seeing surges that were above flu. So if you look at the current surveillance system that Dr. Burks is discussing, is basically you're looking at the flu curve that we're going to watch over the surveillance. We're looking at the normal flu curves over each year, and then we're seeing a pretty significant rise. And we could basically see which are the hotspots prior to them hitting. So we realized that this was something that was going to be a little bit broader across the country. So when the president and everyone else started talking about, you know, the work at home environment and to stay at home, we had three things to really get prepared for as an organization. Number one is how do we move our entire staff, thousands and thousands of people, to work from home? And we were able to do that by about 97% within 2 weeks period. Second, we had to make sure that we stayed very close with CMS, HHS, and the FDA and all of the regulatory bodies to understand how we could help them and support them. So that was also a very important part of my role in making sure that we stay coordinated with them and help feed them data and understand what implications and what guidance they have. And then lastly is to begin to surveil and start to figure out where do we see these peaks so we could begin to tell our customers and our clients where the resurgence are. And we identified about 11 to 12 different areas, and 91% of them actually turned out to be exactly the hotspots. And we were able to determine that somewhere earlier in February, very early February. So that is lessons learned from the past, John. What we're doing right now is we're going to keep that surveillance continuing as we begin to roll out, and people are going to begin to kind of go back to work a little bit. We're probably going to be a little bit more conservative than other organizations in terms of how we create waves out of this, and still keeping the social distancing because we do have very large offices. So we're going to look at all of our hotspots. There's going to be many dimensions, and basically look at what that curve is in terms of emergency room visits that have specific indicators like fever, like certain CPT codes. And we're working with the CDC to try to figure out if there's a way to leverage that and to be able to look at that. Because I think what Anand said is very important, that testing is something that's really important to get mass testing out there. But remember, if you test positive or negative, that's just a point in time. You still have to test the second day or the third day or the fourth day. You don't know if you've been exposed. And then you still have to get the antibody tests out there to see who has been exposed and who's potentially has a lower level of getting the contagion. So there's a lot that we're going to be able to leverage and help the state organizations. Same with Madhu. We could try to see if we could continue to measure influxes into ED, influxes in CPT diagnoses, flu-like symptoms that might occur at a higher level than the traditional flu. So we're leveraging that. And then the second thing that we're trying to do is work with the FDA to start to understand the historical perspective of the disease. In other words, we're seeing the predispositions that some of the patients have, like hypertension. Well, since we have that longitudinal record, we actually could see this. You know, we could see who had hypertensive, what percent, who has chronic obstructive pulmonary disease, who does have diabetes, who's got comorbidities, and begin to really put science behind that. So a lot to do over the next month or so as we continue to monitor. And we could also get lab results and the pharmacy. So we could see the correlation between ACE or ARB inhibitors and outcome. As you saw, we were worried about that earlier in the disease, that it causes bad outcomes. And now we're seeing that it's got a protective method to the ACE inhibitors in the lung. So all of that data and AI is going to help us a great deal to get information, because we're really behind the information curve now. We're reacting more than we're proactively approaching the contagion.
Thank you, Imad. And sort of, you mentioned your work with the FDA. This is going to be a question for both of you, but I'm going to start with you, Imad. So in working with the FDA, sort of you highlight how sort of public-private partnerships are kind of important. Sort of from the international to local level, when it comes to government and the response to COVID-19, how should we be thinking, both as people in industry and people in the public policy sector, about public-private partnerships and the role of government interacting with the sort of private sector?
It's a good question, and it's a question that I believe personally has been answered by this pandemic. I think this pandemic, if anything, and again, one person's view, and you could argue this, that this pandemic shows what a partnership between the private and the public industry could do. You could not get this done by private industry alone, and you could not do this by public industry alone. You both need to be more coordinated. And I think that was a very good out of the gate sort of step that the administration and the regulatory bodies did. They called upon the private industry to help, but they also provided the air cover from a regulatory perspective. And I just think that that is the model to move forward. A lot of the innovation comes out of NIH. A lot of innovation comes out of the CDC and the FDA. And with the private industry, you can really make sure that you can accelerate that. I think for too long, we had two different paths. We had a public policy and we had a private policy world. And we need to bring those together under the same umbrella of regulatory protection, privacy protection, and making sure that we're protecting our citizens, but working together. I think this really proved it during the pandemic.
Thank you, Ahmad. And Madhu, how about yourself? How do you see sort of cooperation and partnerships with governments across the board, from local to the international level? Because I presume you work with all of them.
Yes, I think there's really a lot of scope for it, like Ahmad mentioned. In this first phase that we are in right now, where we're just trying to flatten the curve and reduce the death toll, there's a lot of interaction back and forth. We can't do it without the tests provided by the private industry. We need PPE from private industry. We need masks. We need these supplies. And private sector is very much engaged in that, but so is the public sector. And it has to work together. But when we look past this phase, and a lot of states are now getting to a point where they're reaching their peak, but we start going to the downward curve, we still need that to be able to figure out, when do we open, what industries open first, what kind of support do those industries need from government, what kind of regulatory reform or regulations easing we might need for those industries to start back up again. And as we go into that second phase, then you have to balance between the health of the people and the economic security of that community and that state and the nation as a whole. And so that still requires this public-private partnership. And then you go to sort of a third phase that says, okay, how do we pay for all of the bars and restaurants and schools that were closed, and people that lost their wages, people that are not able to pay their mortgages. And there's this third phase. And then finally, we get to a resiliency phase, where we say, well, what did we learn from this crisis? What do we need to put in place now to do this better? The CDC came out yesterday and said that we should expect the fall to be worse, the winter of 2020, 2021, because COVID-19 probably will return, and there'll still be influenza at that point, so that we may see a surge unlike the surge that we've already seen. So what do we do to prepare even in the short term for that? But then over a long haul, what do we need to do to shore up our healthcare system? Anand talked about it at the start. We're not investing enough in our healthcare system. And so how do we invest in that? And I think there's a very good article by Mark Andreessen who talks about, let's build again. America is known to be a builder. We built great things. How can we take this crisis and come out of it better and more resilient, with better healthcare and with better economic future for the 330 million people in this country, and then globally across the globe? How do we learn from this? I think there's a lot to be learned here, even going to how to provide technology so people can work from home. A lot of jobs can be done from home. We've all discovered that. But how do we provide the tools that people need, a fast internet connection, ability to have laptops at home or devices at home that you can use to connect to the internet with? And so I think there's a lot that we have to do together. And I think it's time now to kind of leave the tired old ideas behind of big government is not the answer, or government is the only answer. We really need to integrate this together and look at a public-private partnership of the kind that built America to begin with.
Thank you, Madhu. And Madhu, you mentioned sort of this issue of sort of what do we do more long-term? How do we make sure we are resilient going forward? So Ahmad, I kind of want you to sort of respond to that point. How do we build long-term resiliency? And even more broader, what do you think the long-term effect of the pandemic will be on the workforce and the use of technology?
So I think there was a politician, I think I know who, but I'm not going to quote who it is, but that said, do not ever let a crisis go to waste. I think our current situation, you know, just the politics of everything and the rhetoric that exists probably is a bit on a high pitch, and no one's really looking. It's terrible that, you know, we see the overwhelmingness of the healthcare. It's terrible that we're seeing the most impacted people are the frail and the predisposition. I mean, I have family members that sit in that bucket that I'm concerned about. And so it is, you know, the toll is high, but there's a lot of positiveness in it. I mean, there's a reason why we said that the post-World War II generation is the greatest generation that ever lived. It's because they went through crisis, and that crisis made them a lot stronger. So instead of focusing on everything that went wrong, no one had a playbook for a pandemic. And anyone who thinks that we should have had that playbook needs to be updated. The pandemic of what happened 20 years ago is not the same pandemic playbook that would happen now. It's not the same playbook that would happen in 10 years from now. So if we put all the blame aside and then looked at what the pearls that we learned from this, we mentioned already, Madhu and I, that working together between the private and the public public and private industries is something that we should continue to work with. I think that is the better for our folks. We're learning also a lot about disparities in disease and how we're tracking that. We've always known that, but we now see that they're prone. And by the way, the prone individuals to COVID are the same individuals that are also prone to the flu. It wasn't as accentuated as before. We're finding out even people that are not well, chronic disease that are not managed well, have a poorer outcome than patients that are managed well. So we all know on this call that hypertensives are high amongst the people that have comorbidities. But if you're a managed hypertensive, it's different than you're an unmanaged hypertensive. If you're a managed diabetic, it's a lot different. So we're learning so much about disease. In terms of, there was 3 stages to this. One of them is getting ready for the crisis. Madhu, you, all of us. We all prepared for that. We had January and February, right? But one can argue, and I saw a question that was on there, was this around in January and February? Of course it was. Not to this magnitude, but Anand mentioned it. All you need is 1 or 2 or 3 or 4 or 5, and you could infect an entire, zip code to some extent. So one was preparing for this. Second is to get through the crisis, and we're smack in the middle right now. But post-crisis is the innovators, the people that are going to get through this, the people that are going to innovate a new way. For us and for everyone else, we're all learning that work from home, we did not see the productivity drop. We saw people wanted to keep their job. We saw people were very responsible. Our productivity when we switched and went to 97% work at home did not drop at all. Wow. If anything, we saw the same and a little bit higher. Now, right now, that's probably something because people can't go outside, people can't do things. So we'll see as we begin to open up the country a little bit more, what are the lessons learned in that? So technology is extraordinarily important in changing the workforce and what we do moving forward. Second, telehealth in medicine. There's going to be a lot of lessons learned in telehealth, and there's a lot of lessons learned in terms of what is a good telehealth visit and what is not. We also are learning what is a necessary elective procedure and what is not. We also, the hospital systems learned how to segregate COVID centers and non-COVID centers. You saw what happened in New York with the USS Comfort. USS Comfort created a non-COVID response for all the others, and then you see others. You see many of the health systems that I'm speaking to right now are going to take COVID centers and kind of try to keep them as COVID centers and be prepared for that, and try to keep the non-COVID area open so you don't have a contagion and infection. So we're going to learn so much from this. And the most important thing, though, that we have to do, I don't know if the answer is just testing, Anand, to your point. I think we do. I don't know if the answer is just if it's just more testing, if it's just more who's been exposed and antibodies and surveillance. I think it's all of them. It's all three. It's not one. It is, we already have a system at the state that's measuring this on an ongoing level. Let's leverage the systems in the state. Let's keep an eye on it. And let's begin to understand exactly where the stockpiles are for extra equipment. I think we've learned right now that this is something that can't be just sitting in DC somewhere, that every stockpile needs to exist somewhere in the city or somewhere in the big urban areas. That's another big learning. So I think our entire way of managing this is going to make us smarter, and it's going to make us, we're learning, John, how to do better ventilation, believe it or not. Right. We're learning better ventilation with these ARDS patients than we didn't know. So I think of all of this as being extremely positive, and it's going to change.
That's a lot of information from sort of rethinking the playbook. I thought one of the most interesting things you said was that your workers' productivity has gone up or stayed the same or gone up as a result of the working from home sort of orders out there. I want to bring Madhu in and sort of bring the question of, we're talking about artificial intelligence. The federal government has been sort of working through ideas on making artificial intelligence work. And there are questions of sort of what the federal government needs to do to support AI in its fight for the pandemic. The Office of Science and Technology Policy has put out certain proposals on the data issues and the computing issues. Madhu, what do you think the federal government should do to support AI when it comes to the pandemic and then more long-term?
So I think in terms of the pandemic, one of the big problems has been data. And I think having access to data that is clean, that is readily available, that's updated on a constant basis, that's a real big problem. And particularly when you start to look at hospital capacity or ICU capacity or ventilator stockpiles in different places, this data is not available. A lot of hospitals are private hospitals. Some of them are nonprofits. Some of them are run by state, local institutions. And so we have a hybrid system, and that data is hard to get hold of that says what is the actual capacity. So that, because the issue, as we've seen over and over in the last several weeks, is when you have a hospital system overwhelmed by COVID patients and the ICUs overrun with COVID patients, that's when we really have high mortality and unfortunately not the standard of care that we'd like to provide to patients that are really suffering. And so being able to have a common data platform and data available for people to be able to do the modeling, the excursions, the evidence-based decision-making that people need to do at state, local levels. Every city mayor, every council at a county level, every state governor needs to make decisions under our federal system. And so they need access to this data that says, what is the capacity and when could I overrun this capacity? Because the decision window is much earlier, right? The decision window for us to get a testing program in place was in January and February. And when you pass a decision window and then now you are into March, it's extremely hard to ramp up and do what needs to be done. So the ventilators that are being manufactured now, they will come out in May and June. We would be relatively past this crisis by that time. So we have to look at those decision windows earlier. And this is where artificial intelligence and data is really meaningful, is because we can take this information and make the decisions we need to make within the parameters of those decision windows early enough that we can take action to be ready for that wave that's no doubt coming. And so I think that is, it's not planning ahead of time, it is planning just in time, but it is before the curve actually occurs. And I think this is really, really important. And there's a role for the federal government to play in that. Also, the federal government has a role to play if you start to do a lot of contact tracing and we have test data. How do we protect the privacy of people? It's the old conundrum that we will face, which is privacy versus safety. How do we provide both? And who has access to this data? What are the other uses that are allowed or not allowed of this data? If people give up their information, what rights do they have to their own information? And what could or could not be done with this information by others? I think those are all very, very important questions to be answered in the context of the pandemic itself. But in general, outside of the pandemic area, I think there's a strong role to play in AI. One of the things that we saw, and I would say, echo what Imad said, we have seen an increase in productivity. We are trying to get our arms around and measure that and say what increase in productivity has there been. But there are programs that we run where we're dealing with a lot of people that are recovering from other disasters. And so we can see that those actions have been more productive since we went into a stay-at-home at the company. So people have been more productive in this period of time. So it'll be interesting, like Imad mentioned, what happens once we have partial opening and people have other things that they can do other than sit at home and work. But I think it proves one very important thing, and I think it's very important for artificial intelligence, because if we're looking at the bright future of AI and say, okay, at some point in the future, a lot of work would be AI enabled, this whole excursion during this pandemic of working from home has been sort of a stair step to that future, because a lot of people who weren't really using technology as an intermediation mechanism for their work started to do that during this pandemic and stay-at-home orders. And so I think that a whole lot of people have become familiar with what they need to do, and people need to have a certain set of technologies at home. We are technology advocates in some sense, and we all like to see the latest and newest gadgets and things. But there's a sort of baseline that everybody needs, which is a high-speed internet connection. You need some kind of iPad or laptop or some other device. You certainly need a cell phone that's enabled, and you might need a Wi-Fi. So there are some core technologies that are needed to be able to operate, and we need to make sure that every part of America has those technologies available, not just in the urban areas, not just in the richer areas, but all across the nation, that people have access to those technologies. Because that's really taking the first step out and getting into a technology-mediated workforce, and then reskilling people so that if they don't have the skills today to work in technology-mediated work environment, and trying to create that kind of technology-mediated capability for them.
John, I think you're off.
Yes.
John, your microphone's off.
Oh, hello. Sorry about that. I was on mute. So yeah, you both talked about sort of the productivity in your organization seeming to go up and the need to adapt to new technology. Madhu also raised the issue of privacy, which I want to sort of bring you into, Imad. So there are a lot of new tools that sort of take advantage of a lot of the data that's out there. But many privacy advocates raise legitimate concerns about, well, are we protecting the data of the patients and just a general population well? What measures and protections should be put into place? I don't think we have comprehensive privacy legislation that deals with sort of the new technology, artificial intelligence, big data that's out there. How would you sort of balance the issue of protecting personal privacy with the benefits of using a lot of data to advance sort of science and public health?
You know, that is exactly this double-edged sword right now that we're facing, is how do we have privacy in a world that we want significant interoperability and significant surveillance. And I think that the old HIPAA rules need to get revisited. I believe that the HIPAA rules were written, what year was it? In the 70s or 80s, or what year was it, John? Do you know?
I think it was actually in the 90s, but pre sort of the rise of the modern AI tools.
So, all right, so 90s. I mean, we just need to revisit those to understand exactly how do they apply with current interoperability, with current data sharing, with providers and providers actually sharing data together. But privacy is a huge issue. And actually bias is a huge issue too, in terms of whether or not the algorithms that you will be applying in AI have any bias to them. And I've talked about this the last time when I was at the bipartisan group, and I keep speaking about it. We need to have a certain level of a standard of data prior to applying algorithm to that data. We cannot apply it inconsistently across different data. In other words, you cannot assess me using retrospective claims without clinical data. You cannot assess, Anand with just clinical data without retrospective, or Madhu just with hospital visits but nothing else. I mean, there is just a lot of a certain threshold of data that we need, that the privacy world has to actually say, to be able to use this data in an unidentified way or in an identified way, it needs to have some level of completeness and some level of an okay by the patient. But it definitely has to get revisited. But we are now at that very scary kind of point where I heard that, we'll use our telephones, and our telephones is going to see, who got, which telephone's using type of, who got in touch with a COVID positive patient. I don't know how you're going to keep that, private. We're looking at technology that is not specific to someone. We're looking at infrared cameras because not everyone could work from home. And so those infrared cameras could begin to look at slight elevations in temperature in the workplace. And if someone goes up by 1 degree, we just kind of come to them in a very confidential way and say, you have an elevated temperature, and so on. But absolutely, we have to revisit the privacy rules, but we also have to make sure that we have to respect them, that we don't just bulldoze them on our way to respond to the pandemic and to a new wave of AI.
Right. And Madhu, I just want to sort of raise sort of similar questions. We talked about privacy. We talked about bias with Imad. Are there any ethical issues that you guys are dealing with regards to sort of using AI in response to the pandemic? Privacy, bias, you can talk about that, or any other issues that you think would be of import for us to discuss.
So I think when we are doing this COVID modeling, we deliberately decided to do it in a particular fashion. First of all, we do a lot of modeling in general, and these are physics-based models where you essentially take the phenomena and you put in algorithms that hard code the relationship between the variables. So you are describing the system through the use of algorithms within that model. And a model like that, we've built, let's say for the Army, we built this kind of model in the 1990s. and it's for atmospheric dispersion of chemical weapons like sarin, VX, and mustard. And these very dangerous chemical weapons that were designed to kill people, essentially. It's the model inside is doing the calculations that say, where would it spread to? Instead of doing that kind of physics-based model, and because of the concerns with the some of the concerns that people have about what exactly are you stating inside the model, we decided to use a different sort of way of artificial intelligence. So Anand talked about R naught values for COVID. And instead of specifying the R naught value, for example, in our modeling, we let the algorithms actually calculate what the R naught value is. It's output, not an input to the model. And so basically it's saying, it's taking the data and then saying, based on the spread that has already occurred, how do we describe that? And then how do we use that to forecast for the future? And as part of that forecast, also outputs the R naught value. So we can see whether the R naught value is going up, which means more people are getting infected for every person that's infected, or is the R naught coming down? Is it below 1 now, which means that we are really on the downward curve, or is it still staying high? And we've seen R naught values in the order of 9 or 10, which is pretty bad. For every one person that was infected, 9 or 10 people getting infected at some of the rising curves that we've seen for various states. So it's taking the technology and applying it to the situation that you have at hand, right, and being cognizant of the issues like the ethics of it, the bias that potentially might be there in the data, and then what is the use for this particular model that you're trying to build. And so looking at the use cases, we determined that doing a model like that actually is not taking in R naught values, but actually calculating it out would be a better way to go about it, and sort of sidestep some of those issues associated with, for example, trying to predict the percentage of exposure and outcomes for, let's say, African Americans. And we've seen in the data coming out of COVID-19 that a lot of the people that have been affected, the African Americans have had disproportionately higher rates of negative outcomes. Right. So trying to take that and put that in ahead of time before you know that, because we did not know that in January, we did not know that in February. So it's very hard to build a model like that earlier. On the other hand, I would just say that some of the things we do know, because despite the fact that COVID-19 is particularly bad for people over 65, we know from disaster management that the elderly are particularly vulnerable. Think of the Fukushima earthquake and tsunami in Japan. Vast majority of the people who died were over 60, 70, and over 80 years old. That's the death rate. When you look at that and you actually see the people who died, that stands. If you go back to Katrina and you say, who are the people that disproportionately died? They were disproportionately elderly. They were disproportionately African American. So there are some commonalities because we have populations that are vulnerable for a variety of different reasons. And regardless of the particular hazard we're talking about, the particular threat, it seems that it affects the same stratas of society more than it affects other stratas of society. And I think that we need to be cognizant of that, even when we are facing an enemy that we don't know as well, which was the case in January with COVID-19.
Right. Thank you. I'm going to start taking some questions from the audience. Just a reminder to anyone viewing, you can ask your questions on Zoom, and I will sort of pick the ones I think will be the most useful. I'm going to do 2-3 questions at a time right now, just because I'm not sure which one of these you guys want to each answer. So first question, how is the use of AI to monitor this pandemic different than the use for any other large-scale disaster? Let's take that as one question. A university student asked, how can AI be used in the university settings? to sort of both fight the pandemic and just more broadly, given schools are closed to learn? Not sure if you guys want to answer that, but I think it's an important one that we can at least throw to you guys. So let's start with those two. So how is the use of AI to monitor the pandemic different than sort of other disasters? And for university students right now who can't attend universities, how can AI be used to sort of help them? So who wants to take a stab at one of those questions or both?
Madhu, you want to start?
Sure, I'll start. So how can AI help for university students? I think first of all, it's pretty important that when people are at home, they can't go to school, can't go to college. There are a lot of online courses, there are massive online universities, Coursera, Udacity. Harvard has put these courses online recently for people to have access to. So just as a field of learning, if 30–40% of the jobs in the future are going to be affected or primarily use AI technology, this is the time to get smart on AI. So we have a real dearth of AI experts around the world, and this is your chance, in essence, as a student to go and learn things about AI while that's available and you have the time available in your hands. Going forward, I think if you're interested in pursuing that as a student, I would just say that when universities are finally open, pursue that as a career if that is what interests you to go down that field. That would be my advice on the AI side for universities. Imad, do you have something to add?
No, I was gonna add. I think that's tough, around the universities. I have kids that are going obviously there, and they're impacted by this. And even if they do it online, it does. The experience of college and all of that is something that obviously that some of them might miss, and we could leverage a lot of the AI to understand what that area in the university, and maybe more testing and more antibody testing and more surveillance around the universities is probably something that could potentially help us, Madhu, in terms of trying to get folks back. I think dormitories is something that's going to have to get revisited. Having 150 people in a closed space is kind of like sort of a nursing home for younger people, and where it's going to just duplicate and multiplicate in terms of the contagion. I did want to respond about some lessons learned around responding to this pandemic versus others or other disasters, and it actually addresses one of the questions. And I think one of the questions says, the role of local government
Yes.
versus just national. And I think one of the person who asked that question, I hope you don't think that Madhu or myself said that the role of the CDC and the federal agencies are the singular role in contact tracing and tests and everything. I think what we learned, another big lesson, is that the state, local healthcare and local infrastructure was extraordinarily helpful in the response to this. It wasn't just the CDC. It wasn't just the federal government. It was truly a state and federal and public and private. So lessons learned on how the public and the private sectors work together. But also another big lesson learned is how the states are doing a very good job. If you look at many of these states and how they're tracking and how they're doing, we hear that they're overwhelmed and there's resources. Yes, of course, with something like this, but they also did a great job. They also did a fantastic job in contact tracing. They also did a great job in testing, once they had a lot of the tests. So I think there's again, what I'm learning from this, John, also is, as I look at pearls, is you can't obviously have a federal response. You can't have just CDC putting out guidelines and it's over. They have to create funding and resources at the state level, because at the end of the day, everything's going to happen at the local level. It's not going to happen from the federal government. They can provide resources, they can provide funding, but the real, whether it's testing, whether it's leveraging the AI, whether it's leveraging the surveillance tools, whether it's leveraging the antibody testing and beginning to put that in a big database to understand where that is, or whether it's contact tracing, it's going to be done at the local level, not at the federal level. We're not going to be sending the National Guards every time we have a pandemic into states and cities and towns. So I think we learned a lot from the surveillance systems of the states also.
So let me add to that. I think preparedness has definitely been one of our strong areas of involvement with states and cities. I'll just compare this pandemic, it's global, to something that was a national crisis, which was Hurricane Katrina. And in 2004, we started working using models to say what would happen if a Category 3 hurricane struck New Orleans, and what would be the consequences coming out of it, and what would you do in the post-response stage, initial recovery phase of this disaster. And so based on all the modeling, we put out a series of consequences. And about a year later, by the way, that hypothetical hurricane that we created was called Hurricane Pam. And Hurricane Katrina occurs about a year later, and it is almost exactly the same storm that we had hypothesized about. And it was really eerily prescient in the sense of what we had said would happen almost exactly happened. One of the things that was important that we did not get right, fortunately, was that we predicted 60,290 deaths from a Category 3 storm striking New Orleans. And the actual number of deaths is estimated to be 1,700. So the difference between those two, if you think about the Imperial College of London and their prediction that 2.2 million people might die from COVID-19 in the United States, if you take that back to Hurricane Pam, Hurricane Katrina, the difference there was because we had in our modeling predicted that 20% of the people would actually evacuate, because that is historically what had happened. About 20% of the people actually left the area that was at risk. And so the intervention, the mitigation that was to be used, which was evacuation, was going to be not as strong. But because of the work that was done, perhaps, and because of the combination of the federal, the National Hurricane Center, the state and the local areas, the actual evacuation was over 90% is estimated. So that reduction of the number of people left in New Orleans reduced the death rate remarkably to 1,700. So these mitigations have a strong effect. And we've seen that to flatten the curve, stay-at-home orders, social distancing. These are all interventions and mitigations to bring the risk down, bring the death rate down, bring the lethality down. So I don't think we have a failure of imagination as much. But we do have, by the way, there was a pandemic playbook. There was a playbook for the pandemic. But what is difficult for us to work out now is how do we take that initial preparedness that has been done, perhaps over years, perhaps over months, and actually deploy it within the decision windows that are available to make effective actions. And so that we need to crack that code. And like Imad said, it is not just at a federal level. It's at the local level and the state level and the federal level. The consequences are very different. If you go back to the 1918 pandemic and you look at St. Louis versus Philadelphia, there were drastically different outcomes between those two cities because of when they put the intervention in place. And you can see that like in the Bay Area in California, they put their shelter-in-place order early. They flattened the curve faster.
Yeah,
reduced probably a lot of preventable deaths.
Yeah, I mean, you're talking about some of the local interventions, and actually a question from a gentleman, Robert Pestrunk, I hope I said that right, is how can local health departments become more familiar with the use of AI tools or get access to those who have expertise? Curious if any of the panelists have any thoughts on that. So this is local governments, how do they build sort of the expertise or at least be able to outsource to get to some of the expertise to be more familiar with the AI tools to respond to sort of this pandemic and maybe future ones and other natural disasters maybe even?
Well, there are a handful of people that are working and building these tools. You know, as I mentioned at the start of this session, IEN has built AI tools for COVID, but there are a number of universities. There is the IHME that Anand mentioned at the start, at the University of Washington. Columbia University has built some tools that are being used by the state of New York, and University of Pennsylvania has some tools. So there are a variety of different science-based organizations that are building these tools for response to a disaster. We did not have a COVID-19 tool in December. So we built that when it became apparent that there's going to be a pandemic and that a tool would be needed. So I think what my suggestion would be is look for science and research-based organizations that are able to be agile when a situation develops and that are able to build those tools. Nobody might have it sitting on their bookshelf today,
Right.
but if they're agile and able to build that rapidly, that's the capability that's needed.
Okay, that's good to know. And Imad or Anand, do you want to add to that, or?
Yeah, I think there's a lot of AI capabilities on all fronts, even private organizations. I would say just be cautious, Robert, in terms of what kind of AI model you adapt, because garbage in is garbage out. And so there was another question that I was reading, you know, Madhu and John, is that it said, should we be looking at social determinants in our AI models and social disposition? Of course, we are seeing outcomes that differ by zip code. You can have two people, same age, same everything, different zip codes, different outcomes, different access to healthcare, different demographics, different social determinants, different behavior. So I would say number one is make sure that when you look at any of the AI models out there, to understand what's the underlying data that's feeding it. If it's just one piece of data, everybody's throwing millions and millions of lives everywhere. We have 10 million. We have 100 million. I threw out we have 130 million. Somebody else threw out that they have 580 million. I didn't know there was that many people in the United States. So obviously there's duplication somewhere. You know, so you can't possibly have 600 million lives in your database. It just makes no sense. At least pick a more realistic number. So, and what type of interoperability are you getting? You know, that's why I like what's going on with CMS and what happened with the interoperability new guidelines that is beginning to create right now financial data and clinical data and social data that's coming together. So I would say, Robert, look at a lot of the organizations, but be very cautious on how you approach them, whether they're public or private, in terms of what the data sort of threshold it is to be able to create AI. The second thing that we've learned is we've learned to look at outside the healthcare industry. And AI has been used in the financial industry pretty significantly, in biodefense, Madhu, like for decades. It's not new. We're just now using it in disease and disease determinants. But it's been used across the board. It's used in security. I don't know if you're aware, there are cameras that could detect whether or not, you know, in Las Vegas, if someone crosses a certain 6-inch line to get something, and they could determine that. There is security cameras that are used in inner cities right now to start to look at congregations and what type of behavior. Now, there's going to be privacy issue and all of that, but technology can be leveraged even outside of healthcare to start to look at certain things in terms of outcomes. And then the last and most important thing that we also learned, because I always like to look forward than backward, is there's at least 20 to 30 different therapies that are coming out to treat COVID.
Wow.
And those 20 to 30 different therapies that are out there, they're not going to treat everyone equally. We're going to need AI to determine how does it respond in hypertensive, how does it respond in diabetics, how does it respond in a cultural situation, it's going to be personalized medicine. Personalized medicine is going to require AI, because you're not going to be able to give one drug that helps everybody the same way. It's going to be based on age, predisposition, kidney function. We knew the medical, pieces, but we didn't know the social determinants of it. We didn't know where they lived. We didn't know other things that are compounding the reaction. So I would say make sure that you pay attention. Not all AI is created equal.
Mm-hmm. Right. And Ahmad, next question, actually sort of building on this idea of personalized medicine. Do you see, this is from Kevin Fahey, I hope I pronounced that right. Do you see a potential for the need for data in pandemic like this to help the transition towards more uniform health data and records? While it could be beneficial to day in, day out healthcare, it could make pandemic planning and response better. So this is kind of about uniform health data and records, if this will sort of help the transition, if that's a desirable thing. I think if you can tie that to sort of this idea of personalized medicine and maybe some of the privacy or security concerns, that could be helpful as well.
Did you say that question came from Anthony Fauci? Is he on the line right now?
No.
Is that Anthony?
Maybe it's his pseudonym. Maybe he's going by Kevin Feige. That's really
just tell him to text me the question instead of asking everybody. Yes, I do think that we will need a very robust data that is going to include, and I don't know how it's going to occur. It's going to be robust about retrospective diseases. That is going to include the epidemiology of that patient. It's going to include the social determinants of that patient, where they live. I do think it's going to get to that level of specificity for personalized medicine to occur. And I do think that will also help us in two fronts. Who is more vulnerable to this disease? I guarantee you that there will be something that we will find out why certain subsets of young people, even though it affects the old people, but why is there certain subsets of young people that are going from like pneumonia and oxygen saturation of 90% to like 70% to death in 24 hours? Something's going on. We know that right now that it causes some intracoagular coagulation in the system. And, you hear stories about all of them. So I do think that we're going to need interoperability and social data to be able to really have personalized, targeted medicine, and who's going to be susceptible and who's going to be at risk. How we do that while protecting privacy is a huge hurdle for us. But if we want to get that specific, we will need to understand, I am of Mediterranean origin. I have the thalassemia minor gene. Does that protect me or does that not protect me? I grew up in a Mediterranean world. I have a vaccine for tuberculosis. You don't, because you grew up in America, maybe. Does that create more protection for me or less protection? It seems to be more protective if I have that much, but we're looking at that data even now. Some vaccines that we've gotten that are cultural, because I grew up in that world, there's some protection. So we are going to be grappling with some very private, questions coming up soon. And it's going to be complicated, but we need to get to that granular level.
Yeah, it's very complicated.
Dude, what do you?
And I want to see if, Anand, do you want to sort of talk about this personalized targeted medicine issue, or if Madhu, you wanted to sort of talk about using AI to personalize areas beyond just healthcare or even healthcare. If you guys want to jump in to take a stab at sort of this personalization issue, let me know. Otherwise, we can move on to another question.
I think I'll just speak briefly and then we can move on to another question. I think it is important to personalize information for people. I'll take it out of the context of medicine and just talk about general response to a disaster. If you have an impending chemical, if a chemical has released somewhere in the highway, you need to get people to move, or you have a hurricane approaching or a flood, you have to get people to move, and different people react differently to information, and they have a perception that they are not at risk when they are at risk. And so being able to provide information to them that is personalized to some degree, I believe would get them to take the actions that are necessary for their own protection. So it's even in the context of where the active actor is the person who you're providing the information to, as opposed to the actor being the medical professional who is assisting this person and trying to have a better outcome. We are different in some senses, and our medical histories are different, our exposures are different. Certainly contact tracing points that out, that there's a different risk to the person who has been in proximity to someone who is now tested positive for COVID. So that information becomes vital in trying to stem the tide of the spread of COVID-19, but it's also valid in a preparedness or in an immediate response scenario.
Thank you. And Anand, do you want to add anything? I want to start getting into this conversation if you.
Sure, I'll just add very briefly on personalized medicine. I agree with Imad. There's tremendous opportunities there for AI to help with the risk stratification of individuals who have COVID-19, and then also to help determine, make sure that the right patient gets the right therapy at the right time. And so all of that, the ability of AI to take volumes of data and help clinicians at the point of care, I think is a tremendous opportunity.
Thank you, Anand. So let's take one more question from the audience. We might start to wrap it up. If anyone has more questions, please continue asking on Zoom. Okay, so this is a very broad question. How do you believe that the role of AI will change in the future? So we're seeing applications today, but in the next 3-5 years, we were going to think of new ways to apply our existing AI technologies that may be sort of surprising to many people. And do you think that regulatory practices will be going to be more stringent going further? So future applications of AI and sort of how regulation you think will evolve in the next 3 to 5 years. And does anyone take a stab at that question?
Yeah, I don't think that first it will require a level of data transparency across many segments of healthcare. Pharmaceutical, we forget that they have data, pharma data, hospitals that have clinical data, clinical outcome, and payers that usually have a very long longitudinal. Right now, all of those are disconnected, John. And to some extent, some level of interoperability to really give us a view of what is going on is going to be required. Obviously, that's going to have a lot of privacy issues on what data do you share. Maybe there's ways to get blinded. I noticed that one of the comments is even if you use cellular phone, that it uses Bluetooth instead of GPS, and that's gonna, it's gonna guard against some of that. But I do believe that there will have to be more data sharing because everything will become more personalized and more granular on what your risk stratification is, on what the course of treatment is. So we learned a lot around how to treat people with COVID, depending on what illnesses they have, comorbidities they have. That will create a privacy issue. And so we'll have to figure out, like Madhu and other really smart people, to give us a way to protect the privacy of the individual, whether it's through Bluetooth or whatever type of technology that will happen to protect the privacy of the individual, or to make sure that they're aware what kind of data is being shared with whom, and they're aware of this. And so I don't see that the regulatory is going to become more and more stringent. I think they're going to recognize the amount of value that we need in sharing data to create real, true interoperability. But we're just going to have to be very cautious on how we approach it with privacy protection.
Great, thank you. So, Madhu, do you want to add to that? Sorry.
Yes, I want to take the conversation beyond the individual to the societal community level, the use of AI tools for decision making, to me, it has been remarkable. I've been in this field for over 3 decades, and there's been a slow progression of the use of information and data and modeling to make decisions. Earlier on in the 1990s, I read some statistic that said that if there's a hazmat event, only 5% of the time did people actually use a model to figure out where the plume is going and to be able to make a decision. So here we are with COVID-19, and we keep talking about models and models and models, and everybody's talking about what models we are using. I think this is a tremendous radical change. And I think that we're going to see the effect of that. It's going to be much better because people have now come to trust a set of mathematical equations that they haven't set their eyes on. They haven't looked at it, but yet they have found a way to be comfortable and to make policy decisions on the basis of this data. And so I think this is a profound shift that has occurred, and that we are seeing that in our state and local partners and our customers, that they are relying on these models, whether they are AI enabled or not. I think that is a very, very good outcome from this horrendous pandemic.
Yeah. I'm going to take one of the slightly more philosophical questions here, and then I'll leave it for sort of closing remarks. So how can AI be used to help healthcare providers decide who gets or doesn't get treatments such as ventilators or not? I think this question, the way I would rephrase it, is AI ultimately able to make value judgments such as who gets care, who doesn't? And this is in the context of scarce resources. Obviously, we want everyone to get care, but when there's scarcity of ventilators and such. And I think really one of the things that this question gets at is, do AIs really, are they capable of making those decisions, or are humans going to have to be involved, whether it's programming sort of a set of ethics into the AI model that people can agree on in the context, or if humans ultimately have to make the decisions completely on their own without programming it into the AI, like the AI maybe says, these are the possible outcomes, human make a decision, or the human says, based on these values, tell us what you think's the best idea, or some combination of everything I've said. So any thoughts on sort of human values when it comes to using an AI system in the healthcare space?
I hope that I hope I'm misunderstanding the question.
Yeah.
I don't think that we ever want to use AI to make a decision on who goes on a ventilator or not,
Right.
and who gets end-of-life treatment or not. Those are family decisions that are made by the patient, their family, and their healthcare provider. That's a bond that should never be broken by just AI, because I don't think we should get to a point. Again, this is one person philosophical that says, no, you're too old, you have too many comorbidities, and you should not be eligible for that level of intensive care. No, we should be able to tell them what the level of intensive care is, and they should make that decision themselves, not an AI algorithm. But I think the AI of the future is really around 2 pieces, which I think Anand mentioned. Number one is to appropriately identify your risk in getting certain diseases and having certain outcomes, be it COVID, be it flu, be it whatever. And Madhu mentioned that whether it's Katrina or whether it's COVID, the outcomes for the elderly and for some social demographics are always worse. So we have a societal issue when it comes to that. So one is, how do we identify the appropriate risk so we can have the best outcome? And second is, how do we leverage AI to have a very targeted, personalized treatment to that? Why is there 20% of patients that go on a ventilator come off for COVID patients? What does the 80% that don't survive have in common? And are we doing something wrong that we could increase that? And so I don't think that becomes a tool in helping us. It becomes a tool in surveillance. It becomes a tool in being proactive versus reactive, but it does not become a tool for us to make human decisions.
Right.
Yeah,
So I would just say that, go ahead, Anand.
No, go ahead.
So I think at a philosophical level, this is like John Rawls' theory of justice. You know, do we save the person who has given 50, 60 years to society and is now in need of a ventilator, or do we give it to the 25-year-old who has many more years to give to society? And it's a bum choice either way. It's not the right question to ask at that point. So I would agree with Iman, but from the perspective that there's too much bias in the data right now. If we actually use AI and data to say, should we give the ventilator to this person or that person? And we know now that the outcomes are not good for certain demographics, certain age groups, then we would be creating a self-fulfilling prophecy, basically, by doing that. And so we don't want to be in a situation where there is a shortage of ventilators. Unfortunately, we have been in a situation in some cases where there's a shortage of ventilators, but I would agree with him wholeheartedly. That is a decision that should be left to the medical professionals, because there is then a real concern about the bias issue that AI has, and any kind of automated way of making that kind of determination would be not consonant with our values as a society.
And Anand, did you want to say something?
Yeah, I just want to, agree and say that I think the opportunity here is for us not to have AI make decisions, but help perhaps add value or guide the decisions that individuals need to make. And if you're a clinician, and you have a patient in front of you and you don't know the correct course of action, the ability for AI to find 100 other patients that are very similar to that one patient, and to have the outcomes of those patients based on a variety of treatments could help you, ultimately decide with the patient and their family the appropriate course of action. So I think the opportunity is there with AI to be supportive in a guiding way. Just as an aside on the ventilator issues or the latest anecdotal evidence, it's perhaps we're actually using ventilators too much during the treatment of severe cases of COVID-19. And it may not be helping as much. And I think there's a little bit of movement actually to start with non-invasive ventilation. And so the science, as you see here, also changes as we learn more. So again, the ability of AI to collate lots of information that we don't have in our fingertips and provide that at the point of care as simply another data point, I think could be helpful, as opposed to sort of, AI making the decision for us.
Yes, I think I heard from everyone, humans need to be in a loop. There's a role for humans. Yeah, go ahead.
Just think about that, Anand, on just something, John, that Anand just said, is that we're learning that positive pressure oxygen is better for you than jumping to intubation in COVID patients. Do you know how much that will be applicable across the board to non-COVID? Because we're now, is it in medicine, based on this, that again, it's the silver lining of what happened. Are we putting too many people on ventilators and jumping to mechanical ventilation as soon as their oxygen saturation goes down because we don't want to do the intermediate step? That is hundreds and thousands of people that will be impacted by that decision that are non-COVID, that will impact potentially flu or any person with acute respiratory distress syndrome. So we're learning so much. We have to store it and we have to become smart with it and make sure that it's equal to leverage it in the future.
Thank you. Yes, so it sounds like humans will have a role in these tough ethical decisions. We can't have machines sort of make ethical decisions. So I think we're all in agreement on that. So we're running out of time. So I just want to give everyone a quick 30 seconds if they want to make any final remarks on sort of what they want people to take away from this event. And I can start with you, Ahmad.
Well, it's a pleasure, and thank you for having myself and Madhu, and and Anand. So I appreciate it. I really enjoyed the questions. If anybody has any questions, it's easy to find me. Imad.rizik@cotivity.com. So if there's anything further that we can help, just the closing session is, everything has got a silver lining. I know we're in the midst of this difficult crisis, or maybe we have at least the apex behind us, hopefully, but also just for everyone to understand that the role of AI shouldn't be something scary. It should be something that is an adjunct. Nothing's going to take over our role. It's just we're going to use it to make us even smarter to our armamentarium of tools, and we should embrace it and make sure that we still protect our patient privacy as much as possible. And we all have that same goal.
Thank you. And Madhu, do you want to give some closing remarks? 30 seconds.
Thank you very much, John. It was a pleasure to be here. Thank you very much for the Bipartisan Policy Center and John and you, and both of you. Pleasure meeting you, Imad. I love your last name, Risk. That's fantastic to be in this field and have that last name. And just like Imad said, if you are interested in having a dialogue with me, please send me an email to madhu.beriwal@iem.com. I think that we can do a lot with technology, artificial intelligence. We are just stepping out there, taking the first few baby steps into this brave new world. And just with this pandemic, I think it proves that this technology can be a power for good. We need to understand its limitations, and we need to understand some of the obstacles that are there, but yet there's a lot of promise, and I think that there's a lot that we can do from here going forward. So thank you again.
Thank you. And Anand, do you want to make a 30-second closing remark?
I just want to thank Imad and Madhu for the great discussion. I want to thank the audience for excellent questions as well, and looking forward to continuing this conversation. Thank you, John.
Great. And I want to thank all three of you for joining us. I certainly found the discussion fascinating and learned a lot. I also want to quickly thank a few of the people that helped make this event possible. Nina Ladonio, Carolyn Cooper, and our vendor, Ventana Productions. They've been amazing to work with. Thank you to everyone who watched this event, and we look forward to seeing you next time. Hope everyone stays safe. Bye.